Well, thank you very much first off, to Nestle for having this amazing symposium and great speakers to hear about ICU and post-ICU nutrition care. And also thank you to you folks. The last day, full day of ESPEN in a hot room, last symposia, last presentation, and you're still here. So really appreciate that. We're going to be switching gears and talking about discharge. And so this is obviously quite different than the ICU and in the general ward. We may have more data and more control over what happens to patients. You'll see that the change means not so good things for our patients, unfortunately. These are my disclaimers and conflicts of interest. So the outline, I'd like to cover why is post-discharge nutrition care so important. I think we've already heard a little bit about that, but what do we know about the typical discharge process in nutrition care? And there's actually not a lot of research in that area. What are the best nutrition care practices for these transitions? And there is quite a bit of evidence, and so I'll be showing you some systematic reviews around that evidence. And then how do we support effective patient care during transition? This gets into my area of expertise, which is implementation. How do we actually change practice and change protocols? So why post-discharge nutrition care is important? Well, just to show you, in Canada, Czechia, and Germany, the proportion of people that are coming into hospital based on the population size, you can see it's huge, right? And so it's about anywhere between 1 in 5 to 1 in 10 of the population will end up in hospital in a year in our countries. So it's a large number of people. Then we look at just the public sector hospitals only. About 64 million people in the EU are admitted to hospitals every year. So again, a huge number of people. And when you think about they're coming in, and often a third to a half are malnourished coming in the doors, and if they're leaving that way, we've got a huge issue with discharge, malnutrition, and nutrition care. If we look at the length of stay, now this is not including the ICU, obviously, but it's the OECD data that we have for 2021, we can see in general, outside of Japan, which is a bit of an outlier, about 1 week is what people spend in hospital. So we're not solving malnutrition in the hospital. We are perhaps detecting it at best and starting them on the road to recovery. We also know from some of the work that has already been presented today, and perhaps other things you've seen at this conference and before, that we're not always being able to address fully the malnutrition. We may be even causing some of the problem, right? So hospital-acquired malnutrition occurs in about a third of adult patients in general and surgical wards in the world. Suboptimal care and intake on wards post-ICU stay is due to food access barriers, including some of the work that was just presented. Spontaneous oral intake post-ICU is as little as 700 calories a day. So it's nowhere near what it needs to be. We know this is from my own work in Canada. Food access barriers are significant. About half of your patients will experience at least one barrier, whether it be being able to reach their tray, even getting food, or missing their food because they were sleeping or at physio or something like that. Longer stay means more malnutrition at discharge. So 36% of people are malnourished at discharge, and if they stay 15 days, they're very likely to be malnourished, 80%. And a quarter of patients, again, this is data from Canada and BC specifically, a colleague of mine, a quarter of patients discharged from hospital to home care in Canada are malnourished, and half of them are at risk of malnutrition. So 75%, all right, are very high risk and ending up in home care. So we need post-discharge care for sure. The challenge is discharge planning is inconsistent. I'm sure it's in Canada it's the way, and I'm sure it's this way elsewhere as well. About 1 in 10 patients will see a dietitian in a hospital. And about 4 of those people, or 5, will see a dietitian at a follow-up appointment. That's a huge number of people who've not seen a dietitian in a hospital and perhaps not received treatment. Patients do not meet the nutritional requirements or recommendations from the hospital as well. So we might say, take 2 ONS a day, and that doesn't happen for a variety of reasons. There might be some of the psychological challenges we've spoken about, or perhaps there's financial challenges or other systematic challenges for these people. But we see that only about 18% will meet a goal of 1.2 grams per kilogram per day for protein. Less than a third are going to meet their sex-specific energy requirements, and less than 15% are going to meet their fluid requirements. So it's not just malnutrition, but also dehydration that we have to worry about. And we know that ICU patients specifically do not recover their body weight post-discharge, and lots of great data was already presented about those issues for you today. So what are some of the consequences of this malnutrition post-discharge? And this is a systematic review based on 26 studies and over 9,000 patients. People that had been admitted to inpatient or subacute care, so not ICU, unfortunately, we don't have that data. But they looked at, were these people identified to be malnourished, have sarcopenia or frailty, and looked at outcomes of these individuals based on that diagnosis. And you can see that for malnutrition specifically, we have 9 studies, and it was typically diagnosed within 4 days of admission. And they found that malnutrition specifically was associated with discharge to a higher level of care, poor quality of life, lower physical function, and 3 of the 5 studies also reported increased mortality. That reported mortality showed an increased mortality when there was malnutrition there. So definitely there's consequences, as you well know, of this malnutrition post-discharge. So what are some of the needs and gaps around this nutrition care? Well, this is actually voices of patients who leave the hospital. So we have from the UK this qualitative study. You can see that patients feel like they're being pushed out the door often to meet a weekend agenda and don't get to stay in as long as they need to. They might not have heard about what to expect when they get home or how to continue the nutrition care post-discharge. Nobody came to discuss what you were thinking about nutrition-wise. And when you get home, what you get in services may be totally insufficient. You can't function at home. You don't necessarily have the home care support or family support to support you successfully at home. No wonder we see huge readmissions into hospital from people leaving hospital. So this poor transition experience results obviously in readmission. And when a study was done actually looking at sort of a review of patients, so geriatric patients, due to coming back into hospital, what were the reasons why? It was malnutrition was one of the big reasons, reduced mobility, risk of falls, et cetera. But malnutrition was a key reason why your geriatric patients come back into hospital. About 1 in 5 patients who stay more than 5 days are going to be readmitted within 30 days. This is actually data from our Canadian study, the prevalent study that we did in 18 hospitals across the country. Oops, sorry. Enteral nutrition is going to be associated with more rehospitalizations, with 23% being readmitted in 30 days. And those requiring home nutrition support are more moderately or only moderately ready to manage that care. So again, they're not feeling ready. They may not have received the education or the support that they need to have that home nutrition support. So it's really important that we have home nutrition teams that support these individuals. And finally, the older patients report poor transition experience. Again, probably half or more than half of your patients are older adults, and there is this lack of care that happens, unfortunately, for them. This is the group we need to target for changing practice in our care. So when I looked at the literature, outside of the work that my group has done in Canada, there really isn't anything describing the nutrition experience in general for people leaving hospital. So the first on the left-hand side from 2017 was based on a study we did 2010 to 2013 in Canada in 18 hospitals. We followed patients and we didn't change anything about them. It was an observational study. We wanted to see the prevalence of malnutrition and what happened to these patients. What's a typical scenario in a Canadian hospital? It was not nice. It was not pretty, what we saw, unfortunately. This study was published a little bit later, but we had data from post 30 days of admission. We called all these patients. We had 747 out of 1,000 patients that we were able to call. 11% reported dietetic care post-discharge, either going to see a dietitian in a home care scenario or primary care or an outpatient clinic. And those who did see a dietitian were more likely to be severely malnourished at admission when we had that data collected. They also experienced or reported more weight loss post-discharge. They had more comorbidities as identified again during their admission. And they had a dietitian consult during hospitalization, which means we as dietitians were not necessarily doing the discharge piece as well as we should have, unfortunately. Skip ahead 5 years, and though it's only 2018 in terms of publication, this was actually conducted a study 2017 to 2018 where we actually changed practice in the hospital to show you that when you do change practice, you have better things going on for your patients. This was 5 hospitals, part of an implementation study where we implemented best practice with respect to screening on admission within 1 day of admission, SGA to assess the person in terms of malnutrition if they were at risk. And the SGA was used to triage people into advanced nutrition care or even higher care than that, specialized nutrition care with a dietitian. Advanced care was MedPass and more nutrient-dense diet, or regular care and discharge planning. And so these 5 sites worked on all those aspects of care, including discharge planning, and we can see an improvement as a result of this. So 42%, the proportion seeing a dietitian was the same, but in terms of the other activities, they were very similar, or higher, I should say. 42% were getting nutrition recommendations prior to discharge, so someone was doing something for them, and they were not feeling so in the dark when they left the hospital. 65% were reporting compliance. You might think that's low, but when you think about it, that's actually not bad. 27% report taking ONS post-hospitalization. What predicted that was being malnourished in hospital, taking ONS in hospital, and belief that they were not doing well with their nutrition. So they'd gotten the point that their nutrition was important and they needed to support it in some shape or form. So let's talk now about some of the best practices in transition care. Well, first off, we are highlighting, as you know, in this symposia, high protein and high calorie nutrition in the form of ONS. And the reason why these are so effective are numerous. Patients often feel overwhelmed at discharge, and so one single thing can, if it can be put into place, might be more effective than many things. They're often still feeling unwell when they're discharged, and so they have poor appetite, they might have challenges making food, organizing food into the home, that sort of thing. All those challenges that impact their food access are going to be present post-hospital discharge. And we know that ONS are going to be concentrated, they're going to get a small amount and lots of nutrition, they're going to be efficient to support their nutrition requirements, easy to consume, they're treated like medicine by patients and the prescribers, and they can be used obviously in combination with other approaches, which we'll talk about with some of the systematic reviews now. So here we have a systematic review post-discharge patients, 14 randomized controlled trials, medical patients only, over 2,000 of them, moderate trial quality. But you can see the interventions were typically multi-component, but some were also just individual component. Excuse me. So dietary advice and counseling was 6 of the papers, food fortification and additional food was in 2 papers, ONS being provided was 5, and prescribed was in 2. So getting the amount right is kind of important as well, right? The key findings that in all of these studies, when we put that data together, any kind of nutrition support to these people leaving hospital decreased mortality, increased their food intake, protein, increased their body weight. There wasn't a difference, though, in this analysis with hospital readmission or hand grip strength. I wanted to pull out one specific study just to show you the difference in body weight when you look at a multi-component intervention, which is on the right-hand side of the slide, and the control group. You can see over a 6-month period that the proportion of people that are changing their body weight, very different, right? When one is getting some kind of treatment versus the group that's not getting any treatment. It's dramatically different. So we need to be treating these patients, obviously. So in this study, it was specifically about ONS, and it showed that we can decrease complications of these patients when we provide them with ONS in and post-hospitalization. So this is all types of ONS in community settings specifically was the focus. There are 44 RCTs, and a meta-analysis including 39 of those studies. And the mean prescription of ONS was over 500 calories and over 20 grams per day. The compliance was about 77%, so not, perfect. And the intervention was on average 74 days, so more than 3 months, right? Okay, or just close to 3 months, I should say. 16 studies have a low risk of bias. What's important to note is those who got any type of ONS at about 500 calories, they have fewer complications. 20% of complications versus those who did not get the ONS, 40% had complications. And those are things like infections, falls, and post-op complications that might lead them back to the hospital. ONS significantly reduced the complications in the meta-analysis, and there was a slightly better effect seen when the ONS was started in hospital. So again, this process has to start in hospital and continue into the community. And so we need pathways of care and systems of care that do that process all the way through. Malnourished patients with ONS had lower incidence of complications, as noted already, and 80% of compliance seemed to be the sweet point with respect to finding significance in terms of these complications. Now let's look specifically at high protein and high energy ONS. And this was a small real-world one-arm study that looked at changes with these individuals. And these were 65 patients who are at risk of disease-related malnutrition. Mean age is almost 60. At baseline, almost all were malnourished, and 19% sarcopenia. When they received personalized nutrition intervention, which was a dietary consult with a dietitian as well as a high energy, high protein or calorie product, you can see the improvements in weight loss, malnutrition, severe malnutrition, and sarcopenia. If you look again at some multi-component interventions, we can see here, these are a little bit more recent than systematic review, so I wanted to include them as well. So in the first multi-component intervention, we had 6 months of counseling, so 8 sessions over a 6-month period, home visits, 5 of them, and as well energy and protein-rich foods, as well as ONS. Improved cognition, improved self-rated health, improved quality of life, decreased depression, and increased performance. That was the study by Blondel. The second multi-component study that was more recent, 16 weeks, it was a little bit shorter than the prior one. Individualized nutrition plan, counseling was given twice, daily exercise recommendation, and a food package for 24 hours when they came right out of the hospital, so they didn't have to worry about food access issues, and having samples of ONS. Here, the readmission rates were not different, but we do see an improvement in energy and protein intake, decreased weight loss, and improved quality of life. So this is one study that was specifically highlighted at this Congress, and it was an abstract, LB016, I think that was presented on Saturday. And we can see as well the benefit of a multi-component intervention with dietary counseling, high protein, high calorie ONS, and physical exercise, and a 3-month intervention. Not only reduced malnutrition, but also reduced inflammation in these patients when considering it by the GLIM criteria. So the challenge is, though, we know we can do things. Things work, right? The challenge is getting them into place, right? And that's, again, the work of what I do as an implementation specialist. So those who are most in need are the ones we have the challenge getting compliance from, right? And we know as well, the more interventions you put into place, this is a sort of against the multi-component method. I believe in the multi-component method, but too many things going into someone's home can be a challenge. If anybody works in home care, you know this sort of happens, that people get overwhelmed with the number of people coming into your home and talking to you about things, right? And so if you can streamline the intervention, at least in the first month to month and a half, especially around nutrition, you're going to actually really support that person much better. And again, we know from work that if we can meet those energy and protein needs in the first few weeks, we're more likely to have some success with that transition overall. So how do we do that? What are the best practices? You've seen this slide now 4 times today. We really like it. It's a very good slide. And I'm going to talk about the last little bit. But this is really good advice for a post-ICU patient, right? The idea that we have to get 150% of predictive equations for their energy, or about 35 calories per day, and 2 to 2.5 grams of protein. As already spoken about in the post-ICU ward, it's impossible to do that in a ward setting. So imagine once you leave the hospital, also extremely challenging to do. So back to the issue, what are the simple things that are going to work efficiently for you? Here's another very nice pathway of care, if you will, came out of Asia, and talks about the different roles that our multidisciplinary team needs to have. So physicians, nurses, dietitians, and physiotherapists. So there's a role for everyone. I'm not going to go through this in detail, and certainly the QR codes here will help you go right to the paper, which would be lovely. And I'm going to highlight this one. This one came out of Canada and under my work as well as part of the Canadian Malnutrition Task Force. And so we had done this original prevalence study, 2010 to 2013. We developed the best practice called the Integrated Nutrition Pathway for Care. We put it into 5 hospitals. Then we put it into 10 hospitals and so we could do it again with no money to the hospitals to do it. And then we said, this is basically the pathway of care that we need to be following in this post-hospital discharge period. So the idea that whatever happens to people in hospital, you need to think about the hospital team doing that documentation of risk and malnutrition, doing that discharge nutrition care planning, educating the patient and family, and providing them with resources to get hooked up to things in their own community, such as Meals on Wheels programs, congregate dining, food access programs like grocery shopping, other things like that. Once they get to the medical home, hopefully there is now communication between that hospital team and their medical home. And we call it medical home because it could be a variety of things in Canada. It could be a community health center, it could be a primary care center, a variety of things. But in the medical home, that might be a week or 2. So you're going to want to reassess the patient and make sure that where they're not going further downhill than you had hoped post-discharge. Initiate post-discharge nutrition plans if they haven't gotten into place. Investigate etiology of various things that might be going on for the patient, especially post-discharge. Provide resources, monitor weight and appetite, etc. But key is if you have a dietitian, to link that person to the dietitian. Unfortunately, in Canada, Ontario and Alberta, which are two of our provinces, do have dietetic care in the community, but not everybody gets it, unfortunately. And often it's not the post-hospital patient that gets it. It is the chronic disease population that gets to see a dietitian, diabetes, that sort of thing. And so we need to be utilizing these dietitians for those high-risk individuals as well. In addition, of course, community-based services. So the prior one talked about what you should do. This one talked about what are the things that are the opportunities you should be putting into place specifically. So just to put that a little bit further for you, the Canadian Malnutrition Task Force, which I'm a part of, we've been in place now since 2010, 15 years of work showing that the improved practices can happen. But we need to do a real good job with respect to getting the grassroots to change practice, and also CEOs and others in hospitals to decide that this is an important practice. We've done a variety of things, and there's a variety of tools that are available for you. Again, at the QR code, you'll see a link to our site. But we have care pathways in hospital and out of hospital, as well as for older adults in the community in general. We've got screening tools for in-hospital. We use a 2-question tool. It doesn't require body weight measurement, so it's a little bit better than some other tools that might have to require body weight measurement. We also provide a basic nutrition care plan. I think this is really an important piece. It allows a physician or nurse practitioner to start thinking about nutrition when there isn't a dietitian available, which is the reality, unfortunately, in community care. And so what can they do in terms of promoting care for that patient? Educating and documenting, investigating, promoting, referring and recommending, and following up. And this is just one thing you can see that's part of the promote component of the getting basic nutrition care plan. So I'm on time, I think. Good. All right, so takeaways. I think I've told you there are many hospital transitions per year. The length of stay is generally short, and malnutrition at discharge is very common. Nutrition care during transition is generally poor and affects outcomes of our patients. Treatment started in hospital and continued at home is best practice, and that's the pathway you have to put into place. Individualized care plans and counseling are essential. Multi-component interventions work. ONS certainly works, and now we're seeing evidence for the high protein, high calorie. Again, thinking about the small amount into those patients who have poor appetite and poor tolerance helps recovery as well. And finally, transition pathways have been created to support you with this better practice. So with that, I thank you, and we'll pass it on for our questions at the end.